So I always ask my students when we're working together, I go, what's worse than a blind eye? And they kind of stare at me like I'm crazy, and they're not quite sure what the answer is. The thing that's worse than a blind eye is a blind, painful eye. And so when it comes to pain, we're just, when it's end stage and a patient is NLP, we are strictly going at comfort at that level. It doesn't really matter if the pressure is down to 12 or less at this point. It's about comfort. If a patient has no useful vision and their IOP is down to, say, in my opinion, 35 or less, we could probably just leave them there and watch them as long as they're comfortable. In those cases which are not, patients aren't comfortable, options would be cyclodestruction, similar to what we talked about earlier. We could do actually retrobulbar alcohol injections. So you basically do your injection behind the eye of alcohol to kill off the nerves so that the pain signal doesn't get sent to the brain anymore. You can also do a nucleation where we remove the eyeball completely. And so it kind of depends on patients' comfort and what they want to do and how aggressive patients want to be. So that would be a discussion to have with them, certainly. There's some cool new horizons as far as treatment goes in neovascular glaucoma. Certainly in the management of macular degeneration, macular edema due to CRVOs, and a few other ischemic retinal processes, we know that intravitreal VEGF injections are becoming much more popular. And one of the cool ideas with this is that there's some thought, do topical anti-VEGF eye drops work just as good as the intravitreal injections?